All right. Hi, everyone. Thank you for joining us tonight. It is January of 2021, so we have all made it through 2020, which is good, and we are excited for the new year. And with that comes a new month and a new celebration from the American Academy of Ophthalmology. And this month in January is Glaucoma Awareness Month. So we are very excited to have Dr. Edward Washington with us today. He is a doctor at the University of Louisville Eye Specialist, which is in the office next door to the foundation. So we work with his team quite a bit, Dr. Sotal and all the staff there, and we're excited to have Dr. Washington with us today. So thank you for joining us.
Thank you for having me. Happy New Year, 2021. We all made it.
Yes, hopefully it is a better year for most people. I would say would say that anyway. So if you don't mind to just give us a little bit of history about yourself. You are a glaucoma specialist, and I may not be saying that correctly, but Dr. Sotal did recommend you for this talk because of your experience with glaucoma. So just give us a little bit of history on yourself first before we jump in.
Well, I'm originally from Hackensack, New Jersey. I spent half my life there and half my life in Georgia, Alpharetta, Georgia. Went to Morehouse College, Morehouse School of Medicine, and I decided to specialize in ophthalmology after I graduated from Morehouse, and had the pleasure of attending The Ohio State University for 3 years. And after I completed that in 2019, I went down to New Orleans and to basically further specialize in glaucoma at the Ochsner Medical Center, specifically in Jefferson, Louisiana, but it's basically in New Orleans. And I worked with Dr. Lawfield and Dr. Nesdorf. So actually applied to become a faculty member at the University of Louisville, and interviewed and presented specifically on different topics of glaucoma, and I got the job, and now I'm assistant professor at University of Louisville.
That's awesome. Well, welcome to Louisville, and we're excited to have you and work with you. So we'll just jump on into, as we mentioned, January is Glaucoma Awareness Month. And as the glaucoma specialist, can you just give us an overview of kind of what is glaucoma?
Glaucoma basically is a specific optic neuropathy, has a characteristic optic neuropathy that produces specific visual field defects affecting the peripheral vision of a patient's eye. Okay, a lot of people like to say that it may deal with pressure, but it's basically, people who have normal pressures that we call normal pressure can actually have glaucoma. So I don't want people to be confused. It's just a disease process with high pressure and affects your optic nerve and you lose visual field. But people with normal pressures can actually have this disease. Specifically amongst glaucoma specialists, we say it's a characteristic optic neuropathy that deteriorates or affects a patient's peripheral vision, specifically that. But pressure is basically something that we treat and has shown to basically help, sorry, getting tongue-tied. Treating the pressure can help patients' glaucoma, basically. But pressure is not necessarily the end-all, be-all for the disease process. Specifically, it's an optic neuropathy with a characteristic visual field loss, specifically the peripheral vision, and can affect the central vision too, and later in the disease process.
Okay. So if someone has, we do a lot of vision screenings, and one of the tests that we do is a pressure test. So we should definitely not be saying if your pressure is fine, you don't have glaucoma,
right,
because that's not always the case.
So, yes, that's not always true.
Very good.
Yeah, pressure is something that we check at every visit. along, not every visit we don't check the visual field, but pressure is something that we check every visit. And it is an important aspect of the exam, but it's not the end all be all of the exam.
It's basically not the only symptom or only.
It's not the, it's not the only.
Okay. So you went into a little bit of this, but what causes glaucoma? Kind of what creates that?
So there's many different causes of glaucoma. Specifically, if it's hereditary and there's no secondary cause, such as trauma or diabetes, or a previous surgery gone wrong, then we would call it a primary process, like primary glaucoma. If there is another cause, a specific cause that we investigated, such as trauma or diabetes or pseudoexfoliation or pigment dispersion, then we call it a secondary glaucoma. So if we don't, we assume most of the time that if we don't find a cause, a specific cause or an event that produced glaucoma, we call it primary glaucoma. But if there's a specific cause or an event that we investigated that was documented, such as diabetes, then we say it's a secondary glaucoma. A lot of patients who have diabetes, who for whatever reason it's uncontrolled for a very long period of time, they can have neovascular glaucoma. Or people who had trauma to their eye, such as a car accident or punched in the eye, like extreme trauma to their globe, then they may have traumatic glaucoma. But if we don't know the cause, it's not documented, there's no inciting event that produced glaucoma in that eye, we call it a primary glaucoma. So there's two types, primary and secondary.
So are there any signs or symptoms that a patient would be aware of that may lead them to think that they would have glaucoma? I know we had talked about the pressure. Obviously, if they're starting to lose their peripheral vision enough for them to notice it, that's a big sign. But are there any more subtle signs or things that people should look for?
Yeah, I'm glad you asked that, because there's many different types of glaucoma. Another type of glaucoma which has symptoms is acute angle closure or chronic angle closure. So to go back to the first question, what types of glaucoma? There's primary and secondary, but there's also open angle and closed angle or acute angle. Patients, as far as glaucoma is concerned, people with primary open angle glaucoma usually don't have symptoms unless the disease process is uncontrolled. Symptoms of glaucoma, like an acute attack meaning something that happened recently, like within a day or an hour or 2 days ago or a week ago or even 2 weeks ago. Patients may have eye pain, blurry vision or worsening of vision or decreased vision, a red eye. And a red eye is basically from the pressure being high, or even loss of vision. So those are like three important things. So think about vision. Is your vision declining acutely? Decreased vision, loss of vision from your baseline, from your usual daily vision, a red, painful eye. Those are symptoms not specific to glaucoma, but those are symptoms that could alarm patients like, hey, I may have something wrong. Let me go to an eye doctor. There's a lot of different disease process that causes those three main things. But it could be glaucoma, especially if you have a family member that who has glaucoma, like a mom or dad or brother or sister, or even grandparents. And then if you have that family history and then you're having some eye pain issues, or, it wouldn't hurt to see a doctor. A lot of times patients with acute angle closure, acute meaning something that happened recently, angle closure meaning the drainage system within their eye is almost closed off, or is closed, may be totally closed off. They have symptoms of eye pain, red eye, decreased vision, loss of vision, hazy vision. They may have nausea, vomiting, may have a headache. And a lot of times they go to the emergency room, and if their eye is overlooked, if they came in saying that they had a headache, no one looks at their eye, and they could have acute angle glaucoma. And it's no fault to the physicians if a patient says, hey, I have a headache, nausea, and vomiting, and they may just give them a CT scan, but it's important to look at the eye too. And a lot of times patients don't know. They may have eye pain and it's referred to their head, and they say they have a headache. And you look at their eye, and there's signs, there's some issues, most likely glaucoma.
And is that pain associated with the pressure because of the drainage closing? Is that?
Sometimes, I've seen patients with primary open angle glaucoma that have high pressure, and I've seen patients with angle closure glaucoma with high pressure, and both can have pain, but usually patients with angle closure come in with pain 9 times out of 10. Patients with open angle glaucoma can have high pressure in the red eye, and probably, sometimes they don't even notice that their pressure is high. So, sometimes if you're having eye pain, it could be pressure related.
Okay. And then you hit on this a little bit about family members having glaucoma. So is glaucoma considered hereditary, or are you at higher risk if a family member has glaucoma?
Yes, so glaucoma is hereditary, specifically the primary glaucoma that we talked about. You can have primary open angle, primary acute angle closure, or primary acute angles. It is hereditary, but not all glaucoma is hereditary, like I told you before. But definitely, if you do have a mom or a dad with glaucoma, or a grandparent, grandma, or a grandfather, or even a nana or mima, or a brother or sister, you should get your eyes checked. And if you have children, like if you have 3 different generations or 2 generations, and you have children, your children should get checked for glaucoma too. Because there is, sorry, I didn't mention this before, there is childhood glaucoma. So it's not just one, it's an umbrella. Glaucoma is a huge umbrella, and it's our job to, examine the patients and test their vision and their pressure, their visual field, and determine, what type of glaucoma they have, and then go and through that, then we can basically, start treatment, which treatment would be drops, or, laser procedures, or even surgery.
So children can have the primary type as well?
Will be specific. If children have glaucoma, it depends on, what age of onset that the pediatrician, pediatric ophthalmologist documented. Some patients may have congenital glaucoma, and some patients may have juvenile glaucoma, like it occurred in the tweens or the teenage years. So within children, or the pediatric specialty, there's different types of glaucoma that can affect children too.
Yeah, that's just something that we've never worked with a whole lot. It's just, I think it's commonly thought of as an older person's disease, but that's not true. So
yeah, it's not. Most of the times, yeah, when you see a patient with glaucoma, it's someone who's elderly, but there are children that have glaucoma, congenital, or it could be related to a disease process like juvenile idiopathic arthritis. So like inflammatory glaucomas, those are like secondary glaucomas. You can have steroid-induced glaucoma from patients who, just on steroids, any type of steroid, and they have high pressure. So glaucoma, again, is just, there's a lot of specific, glaucoma's disease process is under glaucoma, and it's our job to figure it out.
Okay. All right. So we've mentioned that, injuries can cause glaucoma, and having a family history of it is a risk factor. But are there other common risk factors that kind of give you a higher chance of having glaucoma?
Yeah, so being African American puts you at higher risk, or Latino. But I haven't definitely seen within the Midwest a lot of Caucasian or white patients or European descent that have glaucoma also. So you're not necessarily out of the woods. So everyone should get checked, in my opinion. Also, being older, so old age is a risk factor for glaucoma. Having being born with thicker corneas, something that we measure in clinic, or so, not necessarily thicker corneas. I'm sorry, take that back. Thinner corneas is a risk factor. Also, what else is a risk factor? Sorry. Ethnicity, old age, thinner corneas that we put down. Those are the things I'm thinking about right now. Oh, sorry, a family history of having glaucoma that we talked about. Then within specific glaucomas, there's other risk factors that I can't think about right now.
That's fine. That's fine. So is there anything that people can do to help reduce their chances? I mean, obviously you can't change your family history, you can't change your ethnicity, but is there anything diet or health-wise that people can do to help reduce the chances, or?
Nothing that I have heard of, that I've seen in clinical papers, stuff that people can prevent them from having glaucoma, especially if they didn't have a history, or if they have, if they have a family history, is there something specifically that they can do so they don't have glaucoma, or, prevent them from having glaucoma? I haven't, seen any evidence. I think the best thing for them to do, if there's a strong family history, and they are concerned, they should see an eye doctor. Regular eye doctor visits. We tell people, if no family history, no problem, no eye problems, you need to see at least an eye doctor once a year. But if you have a family history of any eye disease like macular degeneration or glaucoma, or if you have diabetes, you should probably see the eye doctor more than once. But you need to see an eye doctor, period, and then they can determine how often you need to be seen within a year. I see patients who have severe glaucoma every 1 to 2 months, depending on what's going on. Patients who have a family history, but there's no evidence of any disease process of having glaucoma. I see them probably 2 or 3 times a year. And patients with glaucoma probably see them at least 4 times a year. But the best thing for you to do is just get screened and see an eye doctor. And then if you ever are diagnosed with glaucoma, you need to come to your appointments. You can see optometrists. Sometimes they refer to ophthalmologist or specifically a glaucoma specialist, but you need to see some type of eye doctor, and, once you have that patient doctor relationship and that rapport, if they give you drops, just take those drops the best that you can. I know it's very hard to take medicine. I've taken medicine before for acute illness, or, been in a hospital, and it's hard to remember. Specifically, I think a lot of people are intimidated by eye drops, or they don't know how to put them in. If you're having issues and the drops are going down your face more than in your eye, then let your eye doctor know so they can show you proper technique. But the most important thing is go to your visits, take your eye drops. If you ever move to a different state or country, go, transfer care, get your medical records and go see that doctor. that new doctor and get established. But I think those are the two main things, like take your medicine and go see your doctor as much as possible. Everything is, on the front end. So if you do those two things in the beginning, I think you have a higher chance of, success personally with your, if you ever have a disease, any eye disease process. If you go to the visits and do what you're supposed to do, do what we recommend, and you give us, feedback on some difficulties, then I think that would help you out. So do as much as you can in the front end, because if you do much as you can in the front end, I think down the line, it's not as much work. But if you don't come to visits, if, for whatever reason, or it's hard for you to, get transportation, you need to see someone closer, get that, talk to your doctor and get that out the way in the beginning. Because, the more visits you miss, the more drops you don't take, it's harmful, and harmful for your vision, your eye, and it's hard to, the right word, it's hard to combat that later down the line.
So kind of what I'm taking away from that is there's no real way to 100% prevent it, but the best way to kind of come out ahead of it, or as to have the best results if you are diagnosed with it, is early and consistent treatment.
Right, like early, so like consistent visits, good patient doctor relationship, find a doctor that you like, that you have a good rapport with. All we have in America, we have access to most, if not all the treatments, and, people may different doctors treat patients differently, but we all have access to the same treatment. But I think the most important thing is for you to have a doctor that you're comfortable with and you feel comfortable going to and telling it all. If you're not taking the drops, just let them know. Don't lie. Don't lie. We're not going to punish you if you can't take them or you forgot to take them. But I think the worst thing to do is say, hey, you are taking them. You're saying you are taking them, but you're not. And then it's like, oh, I don't know if it's working or not. Let me do something else. I mean, because it will not necessarily confuse your doctor, but it's like they're trying to think, what's the best plan of action for you? And you're saying you're taking this one drop and you're not, then it's like, maybe this is not working. Let me give you something else, So I think the best thing to do is to go to see go to clinical visits and take what they recommend and give feedback, as much feedback as possible. If you hate the eye drop, let us know. If you hate, if you don't want to take a drop, let us know. If you're be as honest and, not too, blunt, I guess blunt as possible, because I think if you are truthful, then that gives us a lot of information. Because most of the clinical visit is, we check the pressure, check your vision and visual field and OCT, like a picture of your optic nerve. But I think a good portion of the visit is talking to, and that gives us a lot of information, and we can, do what's best for you and go forward. But yeah, I think there's no prevention of glaucoma. In my opinion, there's treatment and early intervention. So like if you have a family history, you go and see a doctor every year and it's like, oh, something's wrong. Let's see you 2 or 3 times a year. And they're taking pictures and they're doing other tests. And it's like they give you a drop, I think, I think that's what is the best thing. And I guess if you're giving feedback about drops, you hate drops, okay, let me do laser, or maybe, things are not working as we thought they were working. What we first recommended, let's do early intervention, like something like surgery, and there's different types of surgeries. There's new types of surgeries that we have access to now, and new types of devices that some doctors recommend that we do earlier than later, and that can lower your pressure. And a lot of things are within this time period, because all these new devices and treatments, a lot of doctors are saying, these treatments are helping people get off eye drops. And I think that's one annoyance for patients who have glaucoma. They're on the eye drop for the rest of their life, you know, or they're taking drops every day for the rest of their life. And drops are expensive, you know, depending on what type of insurance and what pharmacy. Some of these new procedures are helping people get off of these drops, and it's better sometimes it's better for the patient. Sometimes it just depends on the patient and the doctor. So like some people recommend early intervention. So like I don't want to say I haven't seen any prevention of glaucoma. I've seen early intervention, and early intervention is not always eye drops. It could be laser, you know, it could be an injectable in your eye, an injectable drug-eluting stent in your, you know, drug-eluting device in your eye, or it could be, you know, a MIGS procedure, minimally invasive glaucoma surgery that, you know, we used to do surgery later down the road. Let's say if you're diagnosed with glaucoma in the 50s, and we've tried everything, the drops, the laser didn't work, then we did, you know, surgery, and then we had, you know, we did the trabeculectomy, and we did a tube shunt surgery, and we traditionally in the past did that surgery later down the road after all those drops and laser and the non-invasive treatments were, you know, exhausted. But because these new procedures and new devices, MIGS, people are recommending that, hey, we should probably do it earlier. So I would say the best thing probably would be screening, then early intervention by your doctor. So, you know, a lot of people come in and they don't have, specifically for glaucoma, they don't have any symptoms. That is, you know, 8 times out of 10, 8%, you know, this is a number out of my head. They don't have any symptoms and they don't even know they have glaucoma, you know. And that's the worst thing about glaucoma. People don't know they have it until it's too late. So, but I did answer your question about, hey, is there symptoms of glaucoma? Yes, they are symptoms, but you know, that usually that's something acute. Most times chronic glaucoma has no symptoms whatsoever. And that's what we deal with a lot of times on a daily basis in clinic. It's telling people, hey, you have a disease process, you have glaucoma. You may have never heard about this, but this is what glaucoma is. Your optic nerve is damaged, most likely from pressure. We have to get we tell people, you know, pressure because that's what we treat, but people can have normal pressure and not, you know, and have glaucoma. So, but hey, we tell people this is something that we treat, we lower, and studies have shown if we lower it, we can decrease, what's the right word? Decrease the progression of your disease process. So like, if we did nothing, you probably would have lost a lot of peripheral vision to the, you know, within a year or two, or probably 5 years. There's no way of telling that for a specific patient, but hey, if we did nothing, you know, studies have shown it's gotten worse. But if we give you drops, we give you laser, we do surgery, studies show that, hey, the rapid decline has decreased. You know, you may have peripheral vision a lot longer throughout your life. But yeah, sorry for talking to.
You're fine. So we can basically, the treatment is just slowing the disease, slowing the progression.
No, that's one of the main goals, like slowing the disease process, even possibly to the point where there's no more visual field loss. So I think that's possible, you know, doable goal. That's what everyone strives for. Sometimes it doesn't happen. You know, sometimes we give it our all, drops, laser, surgery, and a certain percentage of patients may still progress. They may still have visual field loss, unfortunately. But, you know, if we do nothing, studies have shown patients will definitely lose something, you know, so we rather do something than nothing all the time and do what's best. But screening, early intervention is, I think, the best road for everyone. Prevention, that's just, you know, I could be wrong. I haven't seen anything, I haven't heard about, you know, preventing glaucoma. We screen for it for patients who have family history. And, you know, not everyone who has a family history will develop glaucoma, but you're at higher risk, specifically. But yeah, we treat glaucoma, and I've seen patients visual field progression stop or slow. Does it stop forever? You know, if we don't come to your appointments, I guess we'll assume the best that it stops forever, but you need to come to your appointments for us to determine like, hey, this stopped your visual field progression for this many years, you know?
Yeah. Okay. I think I just have one last question here.
Mm-hmm.
So in doing some research while getting ready for this interview, I read that currently there are more than 3 million people in the US that have glaucoma. And the National Eye Institute projects that this number will reach 4.2 million by 2030,
Mm-hmm.
meaning that there would be a 58% increase in the people with glaucoma over the next 10 years. I guess, is it possible in any way, in your opinion, to slow this increase? And why is there going to be such an increase?
Is there a possible way to slow? You know, possibly, you know, I think there's different groups of scientists and doctors that are figuring out new treatments or genetic stuff. I'm not, is there a way to decrease? You know, I think like I told you before, screening, everyone needs to get screened early. Like every person needs to at least have a eye exam, you know, every year. And it's, you know, throughout your life, it's hard to, because whatever life events, it's hard to keep up with stuff, but screening, I think is the most important thing. And then early intervention with treatment. You know, I think the number may have increased just because population growth, either through new births or immigration. But I think that's the main issue, or the main reason why there is an increase in number of people who are going to have glaucoma in the next 10 years. Maybe just population growth and whatever means, births and immigration and people coming to the country, you know. But the best thing is to screen and figure out if you do have a problem, and if you do have a problem such as glaucoma or whatever, for us, the doctor, to basically intervene early, and for the patient to come in as much as they can, not like every day or anything like that, but come to scheduled appointments and take their scheduled drops or medicine as directed, and keeping up with their health. It's hard as you get older. Things do, for whatever reason, break down, and just think about it like, you know, getting yourself tuned up and going to the doctor to get a tune up, or, you know, like, hey, I have cataracts now. I need to, you know, get the cataracts removed and have cataract surgery. And patients say like, hey, I have new eyes now. And it's kind of true, you know. But just think about, you know, take your health under your control as much as possible, and know as much about your medication and your disease, or ailment, or whatever you think about it as, and come to your scheduled appointments and do what, you know, we recommend. And if you have any issues, negative or positive, neutral, just give us the feedback and we can go from there. But I think it's important for patients to have control, to know what's going on, and have control of their health and their medicine and how they want to be treated and who they want to see. And if they do that, I think they'll be happy, you know, they'll be happier or better off. I think that's the most important thing, like finding a doctor that you like and then sticking with them. And if you move, you know, you just have to do a little bit of work. It is, you know, it is hard seeing different doctors, and because insurances and for whatever, you know, some offices don't take certain insurances. But if once you find that person you're comfortable with, who you think is competent and friendly and patient, then, you know, stick with them and do what you can do. But, you know, we all try our best, doctors and patients. And we, screening and intervention is, I think, the best. Early intervention is the best thing for this specific disease process. It's hard. It's a hard disease to manage. It's not like, if there's a family history of diabetes, like from the diet, what can you do to prevent it? Easy, exercise. It's not easy, but it's exercise and dieting, but it's not like that. Glaucoma is not like that. Macular degeneration is not like that, the best thing, it's, there's risk. So like maybe, stops, if you smoke, don't smoke, but, it's easier said than done. So like, but for whatever reason, a lot of people, most of these diseases are, a lot of the diseases are hereditary, and we just don't have enough information, scientists or I guess the doctors, to, hey, like this is what we need to do to prevent. We don't have that information for this. This is something that you have or you don't have, or you're at a higher risk of having, and you need to just be followed and screened on a yearly or semi-yearly or quarterly basis and go from there. I wish there was something I can tell you to say, hey, I can prevent, we can prevent glaucoma, but, I don't have that answer, unfortunately.
Yeah. So even though the numbers are going to rise, it sounds like with the treatments that are available, if there is a 58% increase, there will not be a 58% increase of people going blind from glaucoma, because
I don't necessarily think that. I would try to be optimistic and say no, because like if you think that the population is going to hopefully increase and not decline, the population of people, if the population of the United States is going to increase, the population of people who may have these disease process may increase also. But if you think about it, there's there'll be hopefully a rise of new generation of doctors and scientists that can combat this disease also. So that I wouldn't necessarily think like, oh, they're high. Well, numbers wise, possibly, but I would like to be optimistic and say, hey, we're going to develop new things to provide care for you guys. So a higher percentage of people will not go blind from this disease,
And especially if people will take the advice that you've given throughout this video, and do the screenings early and often, and then follow up with doctor visits. I mean, that should increase the chances of, as limited vision loss as possible.
Correct.
Okay.
I mean, there is a small amount, there is a small amount of people that we try our best and they do their best. And for whatever reason that we don't know why, they may have progression. But that's, that's a small, I don't want, this is a small percentage, like it's not huge. But I want to encourage people to take control of their health and their medicine and their decision making, and be empowered to see the doctor and tell them as much as possible within what you see fit is appropriate, and we can go and we can do something, because that's what we're here for. So just because you can't prevent it doesn't mean we can't do something about it. And I mean, there's patients who are quote unquote, blind, that we all say like, but blindness is, we measure blindness differently. There's different levels of blindness. And just because you are subjectively blind, people still have some type of vision. So like they can see light, or they can see hand motion, or they can count fingers, or they can see the big E, or they can see HB or the DO on the Snellen chart. Just because it's you have low vision doesn't mean you have no vision, and it doesn't necessarily mean that you're out the, doesn't mean that we're not going to treat you. If you feel like your vision is getting worse and your pressure is not controlled, then we can do something. We can always try to do something, as long as you want it, if you want. So, and as long as we recommend it too. So I'll tell people not to lose hope. Like if someone says you have end stage glaucoma, or if you have severe stage glaucoma, primary, secondary, open or closed, you know, neovascular, traumatic, or inflammatory, steroid, whatever the cause of the glaucoma, or, you know, and whatever level of low vision, we can do something about it, you know, if your pressure is uncontrolled.
So just
so I'll tell
don't
like
give up hope
people to always have some type of, you know, hope and encouragement, and go from there.
Well, very good. Well, I want to just give you a second or two if you have anything that you want to add or plug in here at the end, but I do appreciate you being on with us tonight, and hope that you have a happy new year. And if you have anything to add, I'll let you do that now.
Well, thanks for having me. Happy New Year. Merry Christmas, Happy New Year 2021. We're all in this together, and let's try our best to do our best, and be there for one another and encourage one another. And there's more power in collaboration and teamwork and service and community. And don't ever feel like you're by yourself, or like nothing can be done, and lose hope. There's always, you know, something, you know, that we can be appreciative of, and something that we can strive towards, and we can work together. So, you know, don't ever feel discouraged and feel like you're alone. I think that's the worst thing that people can ever feel. I think the best thing to do is always, like, you know, talk to somebody, find a group of people who are dealing with the same thing you're dealing with, whatever it is. It could be disease related, mental, or, you know, financial, whatever. And then, you know, talk with them, or talk to a licensed professional, and go from there. But hopefully, you know, 2021 is better. But if it's not, you know, do those things I told you to just do. You know, find family, friends, whoever, and reach out for help, because I think people are willing to help one another. It is hard to be vulnerable, but I think if you're, you know, vulnerable and you're honest, and I think empathy is going to come your way, you know. So be happy and strive for joy, because happiness is temporary. Okay. That's it.
Yeah, well, that's very good. So thank you again, Dr. Washington, with the University of Louisville Eye Specialist. We look forward to working with you throughout 2021 and in the future, and just hope you have a good night. And thanks again for joining us.
Thanks for having me.
All right. Night, guys.
Bye.